Hello everyone, myself Dr. Smita Patil, MS Triroga and Prasuti Tantra. We all have a question whenever a pregnant woman visits our clinic, that in which clinical pathway we have to assess a pregnant woman. So today we are going to see in detail about this pathway. The first thing is detailed history taking, where we are going to ask about her demographic data, age, sex, marital life, etc. And then the dating like LMP, EDD and period of gestation. And then we are going to assess for the general examination and then the systemic examination. After that we are going for a special examination, that is obstetrical abdominal examinations. So today I am going to explain in detail about the obstetrical abdominal examinations. While going for the abdominal examination, explain the procedure to the patient and take a verbal consent. After that, ask the patient to empty the bladder. Then give the position, that is dorsal position with slightly knee flexed position to relax the pelvic floor muscles. After that, expose the area to be examined, that is, as we are going to assess here the fundal height and etc. So expose the area from xiphisternum to the pubic symphysis and cover the remaining area. After that, you stand on the right side of the patient, and if you have a cold hand, make them a warm hand, and with a gentle touch start the examination. In abdominal examination, we are following the steps of inspection, palpation and auscultation. Okay. While inspecting, we are looking over the skin over the abdomen, that is physiological changes in the pregnancy like striae gravidarum, which we usually call it as a stretch marks, and a linear pigmentation over the abdomen, which is called as a linea nigra. And we also look for any skin infections, fungal infection, rashes, etc. And if the patient had any previous surgery like previous LACS or any laparoscopic surgery she has undergone before the pregnancy, we are looking for the any scar marks over the abdomen. After that, we are looking for the contour and the symmetry of the fundus of the uterus, and also any visible fetal movements over the abdomen, and also any visible mass or lump observed over the abdomen. So all these we are inspecting just by looking over the abdomen. Next comes the part of palpation. In palpation, first we are going to assess for the symphysis fundal height, where we are going to measure the height of the uterus according to the gestational age. For this, we are standing on right side of the patient. So with the help of left ulnar border, we are starting the palpation. So start from the xiphisternum and then comes downwards, where the point where you can feel the firm contour of the uterus, make a point there and then make a point at pubic symphysis. So between these 2 points, take a tape and melt. So measure this in terms of centimeters. So here I am measuring this in terms of centimeter. So here this is 24 centimeter. So whatever the centimeter height is there, that is corresponding to the gestational week of the patient. So 24 centimeter means 24 weeks of the patient's gestational age it indicates. So this is one method, but this method may vary person to person because of the depending upon the height, weight and physique of the patient. So there is one more method to assess gestational age clinically. There we are going to use the landmarks over the abdomen. The first thing is symphysis pubis, then umbilicus, then the xiphisternum. So during the 12th week, up to 12th week of the pregnancy, the uterus is just palpable above the pubic symphysis, and up to the 24 weeks of the pregnancy, it is just palpable up to the umbilicus. So in between this, there is a midway. So in the midway between the umbilicus and the pubic symphysis, the uterus is palpable. Then it is approximately 16 weeks of the pregnancy. Then we assess one more landmark, that is xiphisternum. So up to the umbilicus, it is 24 weeks of the pregnancy, and up to the xiphisternum, then that is a 36 weeks of the pregnancy. So between these two landmarks, we are making 3 parts: 1/3, 2/3 and 3/3. If it is 1/3 from the umbilicus, then we can tell that patient gestational age 28 weeks. And if it is up to the 2/3, then we can tell that that is 32 weeks of the pregnancy. And if the fundal height is up to the xiphisternum, then we can tell this is 36 weeks of the pregnancy. And during this, after the 36 weeks, what happens is the head start descending down into the pelvis. So after 36 weeks, there is a slightly decrease in the fundal height. So, at 40 weeks of the pregnancy, you can see the fundal height up to the 32 weeks of the pregnancy. The landmark, that is 2/3 from the umbilicus. If the patient's fundal height is up to the 2/3 from the umbilicus, then that is either 32 weeks of the pregnancy or it is a 40 weeks of the pregnancy, which you can confirm with the detailed history and examination and accordingly the investigations. The symphysis fundal height may vary in certain cases, like the fundal height may be increased in case of polyhydramnios, macrosomic baby, pelvic masses or any fibroid uterus or the wrong date by the patient. And this symphysis fundal height may be decreased in certain cases like oligohydramnios, intrauterine growth retardation, intrauterine fetal demise and the wrong date by the patient. So this fundal height may vary plus or minus 2 weeks in corresponding with the clinical examinations. So after the fundal height, we are going to assess lie, attitude, presentation and position of the baby with the help of different obstetrical manuals. Let's see one by one. That is the lie, presentation, attitude and position of the baby. Here, what is lie? That is the long axis of the baby in relation with the long axis of the uterus is called as the lie. In this case, the lie is longitudinal. So, the lie may be longitudinal, oblique or transverse. Then comes the presentation. So, the part of the fetus which is occupying the pelvic brim or the lower pole of the uterus is called as the presentation. In this case, the head of the baby is occupying the pelvic brim. So, the presentation is cephalic presentation. If the podalic part of the baby is occupying the pelvic brim, then that is called as the breech presentation. Then comes the position. So, the denominator part of the baby which is occupying the lower part of the pelvic brim is called as the position. Here, occiput is the denominator. In cephalic presentation, the occiput is the denominator. So, the occiput lying anterior to the abdomen. So, this is occipito-anterior position. So, the positions may be occipito-anterior, left occipito-anterior, right occipito-anterior, left occipito-posterior, right occipito-posterior or left occipito-transverse and right occipito-transverse. There are total 8 positions of the baby. Then comes the attitude. What is attitude? Is the relation of the different fetal parts with each other. Like the universal position is that complete flexion. All the parts of the fetus are in flexed position. So this is the universal flexed position of the fetal attitude, which is most commonly found. Then we are assessing all these points with the help of different obstetrical manuals. There are 4 different obstetrical manuals. We are going to see one by one. Among the 4 manuals, 3 of them we are doing it by facing towards the face of the patient, and last one we are assessing it with the facing towards the leg of the patient. Coming to the first grip, which is called as fundal grip, where we are going to examine the fundus of the uterus. With both the hands, we are facing the patient and palpating the abdomen, and we are palpating the fundus of the uterus. And here we are assessing for the part which is occupying the fundal part of the uterus. If we had head there, then we can feel the hard and globular structure. And if we are feeling the irregular and globular soft tissues, then the breech part of the baby is occupying the fundal of the uterus, we can tell. Then comes the second grip, which is called as lateral grip, where we are going to assess the lateral part of the uterus. Here, with both the hands, we are putting at the level of umbilicus. So, it is also called as umbilical grip. So, here we fix the one hand and then examine with the other hand. So, here basically we are examining for the back of the fetus. If the fetus back is at the lateral side, then we can feel the convex, hard and continuous part. And if we are feeling the soft, globular and knob-like structures, then those are the extremities of the fetus. So, in the lateral grip, we are assessing for the back and extremities of the baby. Then, the third grip is Paulic grip, where with the right hand, extended thumb, we are placing it over the symphysis pubis and we are trying to grasp the presenting part here. In case of cephalic presentation, if the head is present, then we are going to grasp it and we try to ballot it, we try to move it, and we are assessing whether it is movable or whether it is get fixed over there. And if it is a hard globular structure, then cephalic presentation. If we get any soft and irregular structure, then that may be the breech presentation. So then comes the fourth grip. Here we are facing towards the feet of the patient with both the hands keeping parallel towards the inguinal ligament. We are going downwards and backwards, and it is the continuation of the third grip where we are going to assess whether the presenting part got engaged into the pelvic brim or not. Suppose if it is a cephalic presentation, then both the examining hands get divergent here, and if the head is above the pelvic brim, then I can grasp the presenting part and both the hands are converging here. So this is the confirmation of whether the head is got fixed, engaged, or it is just above the pelvic brim. In continuation with this, to assess the degree of engagement, we have one more method which is called as the fifth formula, where we are going to assess the degree of engagement. So consider if in a cephalic presentation, we are assessing it with the palm, that 5 fingers, so it is called as fifth formula. So if we are able to palpate the sincipit and occiput of the baby with the 5 fingers above the pelvic brim, then the head is not engaged, it is completely floating head. And if we are able to palpate up to 4 fingers, then the head is above the pelvic brim. And if we are able to palpate up to 3 fingers, then the head has reached just up to the pelvic brim. And if the head is got little bit descent, and if we are just able to palpate up to 2 fingers, then the head started getting engaged. So here we can say that the head is got engaged. And if we are just palpating with the 1 finger or less than that, we are unable to palpate the sincipit or occiput, then we can tell that the head is in deep engagement. So these are the level of engagement we can assess with per abdominally. So what is the importance of this fifth formula is that here we can avoid the per vaginal examination. The recurrent per vaginal examinations can be avoided with the help of per abdominal examination, and we can assess the degree of engagement, and it is very helpful during the period of labor. It completes the palpation part. Let's see the auscultation part. So in case of lateral grip, we have located the back of the baby. So the FHs are best heard at the back of the baby because the baby is in universal flex position. So we can't palpate FHs on the front of the baby. So the FHs are heard in the back of the baby. So in lateral grip, we have assessed the back of the baby. Then we are locating the point. In case of cephalic presentation with the occipito-anterior position, the FHs are heard on the anterior part of the abdomen, where midway between the umbilicus and the superior iliac spine, anterior superior iliac spine, somewhere midway, we can listen to the FHs. And in case of occipito posterior position, then the FHs are heard slightly lateral towards the abdomen, that is in the flank of the mother. And if the baby is in breech position, then we can hear the FHs above the umbilicus. Once we located this, then we can count the FHs with the help of stethoscope. Here the FHs are counted best with the help of bell. So we can count with the help of bell of the stethoscope, or if we can count it with the Doppler machine. We can count the FHs. In this way, we have completed the obstetrical abdominal examination with inspection, palpation and auscultation, and we have also seen the different obstetrical manuals and their clinical importance. So here we are getting the normal findings of the patient, but there are certain conditions where these findings may vary. We can our clinical judgment may miss. Such conditions are like polyhydramnios, where there is a excessive lycoramny, where you are unable to palpate the fetal parts or you are unable to examine the presentation, etc. Same with the multiple pregnancy, where you can feel the multiple fetal parts and you may get confused. And if the patient is having any pelvic masses, fibroid uterus, that also interfere with the presenting part and the fetal parts, there also we may get the confusion. So whatever the findings we assess clinically, that findings we can confirm with the relevant investigations. Then with this help we are assessing, and with the help of findings we are advising the patient relevant investigations, and accordingly we are going to plan the treatment for the patients. Thank you.